just also the surface appears to be very, very fine grained as you get close to it. It's almost like a powder down there. Very fine. I'm going to step off the limb now.
That's one small tip for Phaco. One giant leap for ophthalmology.
PhacoMentors.com.
Welcome, guys. Hi to everybody. Today is one of those amazing days in which we say good morning to one part of the world, good evening to another part of the world. We have an amazing panel today from very different countries. We're going to present it in a couple of minutes. And thank you for being here. People is connecting, so please tell us where you guys are from. We would love to see to which part of the world we are reaching. We have many people from, the great Cheriano is from New York. Ishtak is saying hi. Julio Martinez, hi. Tell us where you guys are from, right? We would love to know where you guys are from in the chat. Please write to us. And we're going to start. We're going to start today with this platform, talking a little bit about the Phaco mentors and how we are gathering many colleagues from around the world, as you can see, to help you in this journey to become the surgeon you want to be. Okay, this is a journey we need to do together. Now with technology and with a good methodology, you can become a cataract surgeon. So here we are building this amazing community, to help you in this way. Today is one of those days. I like this slide because it's about making our comfort zone a little bigger, right? We're going to talk about something very specific, and all of us, we love this. We love Phaco, but for another colleague that does retina, sometimes these guys, they cannot believe how we're talking about only dividing the nucleus, but it's gonna be very important, or you're gonna learn so much. This is a day to expand your comfort zone. Again, as you know, guys, social media, we are in all social media, so if you follow us, it's better for us to be in touch with you. We're practically doing one activity per week, and we have an amazing surprise in a couple of weeks. Okay, it's gonna be big, and you're gonna enjoy it big time. So Facebook, Twitter, Instagram, there are connections, and YouTube, it's our virtual library, so you can connect with us. We have a WhatsApp group. We're using all technology we can. So everybody there who is interested, you just need to take a picture from this QR code, and you're gonna directly enter into our WhatsApp group to be in touch with us. Okay. Let's see, because there's many people writing. Rina from Indonesia. People from Mexico, Sonora. So, they need to be working, but they're watching us. Thank you, guys. Noor, Hafiza, hi, how are you? From Indonesia too. Many people from that side of the world. Amazing. As I was saying, YouTube, our virtual platform, you can enter every time you want. And we're going to start fast today because we have many great platforms. I live in a very noisy country. You need to know that. That's the guys who will buy you, will sell you the gas, and they scream a lot. So welcome to Mexico. Okay, so Dini, it's an honor to have you here from Indonesia. Yeah, great pleasure to have you. Kang from Malaysia. Kang, thank you for being here with us and giving us your time. Vishali, Thank you for being here with us from India too. Julio, great friend from the house. And my brother from the other side of the world here, Ishtiake, helping me coordinating this amazing activity. So this is gonna be the key for today, right, guys? I love this light. I actually love the music. This is what we're gonna talk about. What do we need to do? We need to divide the nucleus. Okay, that's going to be very important, and this is the first tip of the day. Every time you see one of these speakers, ask about the posterior plate, because when we're cracking the nucleus, even in hard cataracts, that's going to be the most challenging thing. Okay, that's first tip of the morning here and late. Second thing, every time we are evaluating a technique to divide the nucleus. This is in Spanish, but I'm going to tell you there is three things that need to be in your mind. Three things that you need to be always aware. First thing, endothelium, guys. It will always remember you, always, no matter what you do. So every technique you see, you need to understand if you do. Let's stop it here. If you are doing ultrasound, remember that endothelium is going to remember you, that guy over there. Okay. The second thing is that some many techniques, they seem so nice and so the surgeon is so skilled, but here there is 4 microns. There is a structure of 4 microns that if you break it, the surgery will change completely, especially if you're dividing the nucleus, because you have the entire nucleus inside the bag. Okay. Second thing to be aware of. And the third thing, for those guys who like to chop or ultra chop or like to do great maneuvers, the sonula. The sonula, right, has some specific tension. So if you want to have success, you need to take care of it. Okay. And then again, we always say about this journey, we will love to see how becoming a cataract surgeon is a journey. It's not from one day to the other. And actually, we can always start learning. For example, Ishtiake, with him, we saw a technique a couple of weeks ago. Now he's trying it, and now he's going to show us his result. So we are always learning, even if you're an expert like Ishtiake. So this is the key, right? Find the mentor. This is why Phaco Mentors is here, right? The mentor and the feedback is going to be so important. And the 4 tips for you guys: you want to start a new technique, set a goal. Set a goal. That's very important for your brain to say, okay, I want to do this technique. This is going to be the plan to make it add some emotion and meaning to everything you do. Feedback, measure your progress, have a mentor, and deliberate practice. What is deliberate practice? Is to practice perfectly, and we can help you with that too. So we will love to we would love to hear from you. We have 2 questions for you guys. So, Lisandro, please, we're gonna first, and this is very important, let's try to understand how important, okay, how important is to divide the nucleus in phacoemulsification. Lisandro, porfa, si puedes poner la pregunta. And the second thing is, which is the technique you use the most at this time? So when we know a little bit about that, we can start with our guests. Let's see if we can upload the questions. If we don't have them, we can leave it for later. And Visali, please just get ready, because you're the first. Okay, there you have it. So for you guys to understand, the first question is kind of tricky. I want to know in your brain how important is for you to divide the nucleus. We have an amazing colleague called Dr. Jorge Jaramillo, who says that his effort is almost entirely to divide the nucleus. And then, okay, the fake emulsification, it's easy. If you're more about fake emulsification, but you didn't divide it correctly, then you're gonna have some problems. Okay, so let's see what people are answering. Please, everybody, Okay, so 50-50, interesting. Okay, almost 40% of people said 50-50. You need to divide it, but then what happens afterwards, it's important. Another 30% said 80-20. So there's people that saying that dividing the nucleus is important. The second question, please. The second question is about, it's about which technique do they normally use. Let's see if we can give them new techniques. Okay, we ask the audience to go fast, but basically we use divide and conquer, stop and chop, vertical and horizontal chop, and the pre-chop. I am a special lover of the pre-chop. Let's see if we, Ishtake too, right? You like the pre-chop, right?
No, actually I tried once or twice, but
Oh, I need to do some
Yeah,
inception in Ishtake, I think.
I need to learn from you. I'm going to do it. Don't worry.
Okay, so let's see what people says. And Vishali, you can get ready. You can start sharing your screen. Interesting. There is many different answers, but divide and conquer is number one, and I think it's interesting. So we should talk about how you need to sculpt. Okay, then 26% stop and chop. So Vishali, it's great to have you here. Welcome.
Thank you, Dr. Ivo, and I really feel so happy that this is my first virtual meeting that I'm attending as part of this lovely group, Phaco Mentors group. I do follow it a lot on WhatsApp. I have not been writing a lot, but I think I need to change that, and you'll see a change from tomorrow. And I loved the part where Dr. Ivo really, he summed up the entire meeting in the 4 points that he gave us. And how do you go about it? So I think I love the part where he said that whatever you do, whenever you chop or you sculpt or you divide and conquer, you need to keep in mind that the cornea, the zonules and the bag, they're all interrelated, and they will bear the brunt of whatever you do and how well you do it. So I will try to be as brief as possible. But I think that sculpting is one of the most important steps, and yet it is one of the most underrated steps. We have heard courses and courses on how to chop and how do you remove and how do you protect the cornea, but nobody really talks about sculpting. So I'm very happy that we had this topic to begin with. I have no financial interests, but in my mind, how long you should sculpt, how long and how deep you should sculpt depends on many factors, but basically it depends on the grade or the hardness of the cataract and what technique are you going to use to then divide the nucleus. So it would be different for divide and conquer, and it would be different for chop. It also depends on the size of the pupil, for example, if it's a small pupil versus a large pupil. So these are the things we need to consider. But what I like to begin with, that when you do a phaco surgery, there are 3 distinct parts of the surgery, depending on your technique. So if you are a sculpting person, that is your first step. Second is division, and third is then removing the divided fragments. And I love that poll question where at least 60% of us believe that dividing the nucleus is, if not 80%, at least 50% of the important job of the cataract surgery. So I think the sculpting and nucleus division and the removal, they all need different parameters. That means they need a different energy setting, they need a different flow rate, and they need a different vacuum and bottle height. So for example, if you're sculpting, you don't need a very high vacuum. You don't want to suck anything. You just want energy. When you're removing, you need more vacuum and energy because you want to first bring that fragment and then eat it up. So that is something I think if we understand to begin with, in whatever phaco machine you are using across the globe, we need to have different boxes or different sets of parameters for sculpting, for chopping, and for division. I've seen a lot of people who just have one setting, nucleus and epinucleus. There's just 2 boxes or only 1 box, and we never change. Now that is why we can end up with either difficulty in surgery or less than optimum outcomes. So for example, you have a very dense cataract like this, and I'm sure most of us Dr. Dini, Dr. Ishtiaq, Dr. Ivo, Dr. Julio, Dr. Ken, we all see these a lot in our practices. So when you're sculpting for a dense cataract, typically most of us today use some form of chopping technique, horizontal, vertical, or a combination. Now for that, we need to keep in mind that the trench should not be very long, it should be small, it should be central, and it should be deep, and preferably within the rexis margin. Why? Because the longer you sculpt, you are spending more energy. I think half of your CDE will be wasted in sculpting, or more than half, if you make a very long trench in a hard cataract. Therefore, you need high energy when you're sculpting. You don't need a high vacuum because, in fact, you don't want anything to get sucked or get occluded. You just want high energy, very moderate, about 150 or 200 millimeters of vacuum. And your flow rate, that means the rate at which things are coming to your phaco tip, also has to be moderate. Maybe about 25 cc per minute will do because you don't want anything coming to you. So this is an example of a really hard cataract. And the reason I'm showing this is to highlight that this is a kind of trench you would want to make. It is small, it is very deep, so you can actually see that golden plate, and it is central, it is within the rexis margin. Now, why it is important to have a small and central trench? Because a lot of times these pupils, as you can see in this particular case, will not be very large and they can go down during surgery. So you don't want a large trench where you can't see what is happening when you are dividing. So it is always a good idea to have a technique where you can chop also within the rexis margin so that if your pupil goes small, you can see what is happening. So this is something that you would aim for in a dense cataract. Now, again, more and more of us, especially as we become more refractive surgeons, we see a lot of soft cataracts. And soft cataracts, the sculpting is very different. In any cataract, either a dense or a soft cataract, the very important thing is not to push your nucleus. So don't rock. A lot of times, and this happens when you are starting off, when you're a beginner, you don't really think, you're so busy or so worried about getting that trench that you don't realize that the subincisional nucleus is being rocked when you are pushing your phaco tip. So therefore, make sure that when you sculpt, your phaco tip should not be occluded. This is very, very important. If there is occlusion of either viscoelastic or by the lens matter, then you can cause complications, including zonular damage by rocking the nucleus. So always raise your energy. If you feel that you're not being able to, it's like shaving through a butter. If you can't do that shaving very well, please increase your ultrasound power, but don't push, no pushing. Therefore, your wrist should be stable. It should be a movement like this versus this. So these are very fine tips, like not moving your elbow and only moving your wrist. This is something that you don't think of, but if you do pay attention, you realize that this is important. Now, I have learned this technique from my father. And here, basically, I don't want to show the technique. The point I want to highlight through this, this animation is that if you're doing a chop technique, you need a decent depth of your sculpt. It should not be very superficial because you're going to occlude your tip and then have a vacuum. Now, to hold that, if it is, let's say my phaco tip was very superficial, then this vacuum will only extend till this much part. It will not go to the depth of the nucleus. So you can't have an effective chop also. Therefore, have a deep trench and in the wall of the trench, occlude somewhere here. So junction of upper 1/3 and lower 2/3. That is what I think would be useful. So this again is to show that when you chop, you want a good vacuum, so therefore your trench has to have a good depth. Also, like Dr. Ivo pointed out, it is this posterior plate which is always going to be a problem. So the deeper your sculpt, easier it is to then easily separate out this plate. Now we move to soft cataracts. Again, sculpting is very different because in hard cataracts you want small, you want deep, and you want to use a high energy when you sculpt. It is just the opposite in soft cataracts. So go with minimal ultrasound because you don't want to eat up anything and reach the equator. Use minimal ultrasound. use minimal vacuum. I would use only about 100 or 120 millimeters of vacuum and a low flow rate, about 20 cc, even less than that can be done. But try to make a long trench. That means go towards the equator, and so that division becomes easy. You are not going to be able to chop a soft cataract. So you will have to change your technique, a divide and conquer or a new modified nucleotomy technique. So you need a thin, uniform sculpt from center to periphery. Then again rotate the nucleus and do that on the other side. So here you want a long trench, deep trench, uniform, and you want minimum energy so that you don't pour through. I have caused more than one time PCR during sculpting in a soft cataract, and I'll show you that case. So here is what all our surgeons at both our hospitals in India we use. We do this trenching, and you can see that the flow rate, which is highlighted in this red box, is only 14 cc per minute. That means we are not worried about attracting the iris or the post-equatorial capsule. And with low energy, you can see that the ultrasound has been, torsional ultrasound has been set to only 20%. You don't need 50-60%. And just keep sculpting so that you have a uniform groove. Start in the center, go to the periphery, and now use your two instruments in that same wall and just move them laterally, and it will easily separate. So this is the technique that I like to use, and all surgeons at our hospitals like to use for soft cataracts. Now you rotate and repeat this in. So you have you can make 4 halves of this. So that is what I wanted to highlight. The bottle height is also modest, but the flow rate is low. So I'm not worried about anything getting sucked in. That is the most important thing, and energy is very, very low. Now another cataract, which is also soft and in a high myope. So I'm using the same technique. But what I did want to show here is, if you look at the IOP, my machine gives IOP, but basically it is bottle height. You have to drop your bottle height because otherwise your chamber will be very deep. So when you are sculpting, you are not removing anything. So you just need moderate maintenance of the chamber. You don't need a very high bottle. Otherwise that irrigation will create a deep chamber, difficult to sculpt. Also, it will cause iris prolapse. So lower your bottle height when you're doing this in high myopes or vitrectomized eyes. Again, same thing, I wanted to show 14 cc flow rate, and you can see that these all three are different surgeons in these clips. Some of them are fellows, trainees, but they are not scared because the flow rate is very low, the energy is very low, and the vacuum is also 100 millimeters. So we are never, and we want to make sure that we be like this. Our bevel should be like this so that we don't block it at any point of time. You can see here this vacuum, it is not reaching the preset. So I think that is what I would like to highlight. In short, low vacuum, low power and low flow rate will help us and make a long trench, but make it uniformly deep, especially in the center. Because if that center does not divide in a soft cataract and you remove everything else, it becomes like a bowl. And then to remove that epinucleus bowl is another challenge. And again, consider lowering the bottle height. Now, one special scenario of posterior polar cataracts I just wanted to discuss. And again, this technique we all follow at our centers. So here sculpting is also a very important part of this technique. What we do here basically is we are going to create a central small trench and then introduce a special cannula, hydrodelineation cannula, and then do hydrodelineation. This is from inside of the nucleus, you are passing fluid to the outside. So it is called inside out delineation. And this ensures that sometimes while doing conventional hydrodelineation, if you have not made a trench before you do hydrodelineation, you can end up with hydrodissection. And we all know that in posterior polar cataracts, this can lead to rupture of the posterior capsule. Again, a video of what we do. We make a small trench and then we insert this simple hydrodissection cannula and inject fluid so that we get a nice delineation of nucleus. So this is where again sculpting also comes in very useful in posterior polar cataracts. I'll show you just 2 short quick videos of complications that can occur during sculpting. One is, first thing, when you enter the eye, typically we all have a tendency to go into foot position 3. Now, if your eye is full of viscoelastic, particularly dispersive viscoelastic, it will block the tip, and when you apply energy to that, it causes instant wound site thermal energy, thermal injury. And you can see this in this video that the phaco tip here, the incision looks okay. The phaco tip is entered, and look at the vacuum. It is occluded, and foot position is in 3. So instantly you see this white. So the incision is charred. Now you have to suture this incision. It will heal badly. So this is something, do not go into foot position 3 as soon as you enter your eye. First remove some viscoelastic in foot position 2, then start giving energy. And the second thing is posterior capsule rupture, particularly in soft cataracts. So here is this case where I'm doing this 4-quadrant nucleotomy, and I think everything is going fine. But then I realized that there is a posterior capsule rupture over here because I sculpted too deep. So be a little careful by lowering your energy. And I don't want to go on further with this, but I think this is what I wanted to share. And I will appreciate the comments from all the panelists also.
Thank you very much. So complete, very, very complete. There was a lot of skill transfer there. Ishake, you have some comments?
Yeah, excellent points mentioned by Vaishali. And she has mentioned that, the depth has to be adequate. If you go too much, you can touch the posterior capsule. And if you are inadequate of depth, separating it, whether you are doing divide and conquer or stop and chop, can be very difficult. And you have mentioned that the posterior plate, that is the most crucial thing. Another thing Vaishali has rightly mentioned that, don't rock the nucleus. That means using the appropriate energy while you are sculpting. Okay, so like if the cataract is harder, use more energy and go slow. Let it emulsify and then forward your tip rather than just pushing it, because then you're going to hurt these zonules. So excellent presentation, Vaishali, and many tips to learn from it.
Thank you.
Dini, it's an honor to have you here. Amazing title, by the way. So you can start whenever you want. There you go. I think you're mute.
Dini, you have to unmute, please.
Okay.
And there you go.
Yes,
and then you can start.
Yep. Hi, everyone. Thanks for having me. Thanks for Dr. Istiake and Dr. Ivo as a coordinator. Same as Dr. Faisali, this is my first time be one of the part meeting with many people from the world. Today, I would like to talk about divide and conquer. Let we call it DNC. Why we need to know DNC? Because in my experience, as a beginner, DNC is a basic technique of Phaco. Soft to hard cataract, we can go with DNC. Three principal keys of DNC are key number 1, good depth and good construction. It would be better if we could perform parallel and rectangle wall for easier cracking, as Dr. Faisali said, uniform sculpting instead of the bed sculpting, which is more trapezium shape-like. And also the length of strands should not be eccentric. Then key number 2 is the both tips should be in a base of strands, so we can make adequate power to crack the nucleus. Compare with incorrect position, for example, the left picture, when we place in the middle of nucleus, the power of cracking will be inadequate and improper motion. And key number 3 is a right movement. If you get good trends, good instrument position, but the direction of cracking improper, you will get difficulties to crack the nucleus. Open the base of trends with the pivot in the top. One published related divide and conquer from Dr. Susan Jacob explained there were two kinds of cracking. Conventional cracking with the direction parallel, it's easier when the angle of incision less than 90 degrees to each other, and cross cracking with make a cross direction between two tips. it's easier when the angle of incision 90 degree to each other. This is my video courtesy from Unda Anai Hospital. We can see the movie on top is cross-cracking with the angle 90 degree, and below is conventional cracking with the angle less than 90 degree. In my experience, I was facing difficulty in doing cross-cracking. Why? Turn out my main incision and second incision less than 90. So the next step, I have difficult to divide nucleus. When we can perform cracking, start from the trench across of incision all the way down to the middle and stop at before main incision. The next film, okay. In this video, describe about stop and chop technique, but after cracking, welcome to impale step. The Phaco tip is little bit superficial and leads to failed chop. What I want to underline is when we face this kind of situation, we can go back to the NC technique. In other situation, in this video, we have a good trends, but we still hard to crack. We can use chopper and other hook or spatula to do manual cracking. Other technique with pre-chopper will explain by Dr. Ivo and Dr. Julio. And this video from KMU Eye Clinic shows us the process of DNC is starting with making two trends perpendicularly and sculpting from superficial and go deeper. The important one, as Dr. Faisali said, avoid posterior capsule rupture. So the direction downslope, then upslope, according to the curvature of the lens to avoid PCR. After that, the next step is cracking. Remember, when perform cracking, place the instrument on the base of trans. The next step is segment removal. Please be mind, Phaco tip should be tried to always keep in central to avoid posterior capsule rupture, because usually as a beginner, we chase the segment. With the chopper, help us to place the segment in front of Phaco tip. So once again, please don't chase the segment. DNC is beneficial for any type cataract and as a solution if we get difficulties situation. As a summary, always remember for successful DNC are correct groove, correct position, and correct motion. Thank you.
Simply amazing, Dini, simply amazing. I love the last slide. I think it's very important, very, very powerful for everybody. I don't have anybody of the panel have some comments. Kang, Dr. Kang Fong, you're next. You can start sharing your screen.
I like this slide, where she showed that if you fail in chopping, which happens, when we are learning, and a little bit soft cataract, then you have to go back to divide and conquer. So even if you are planning to learn chopping or horizontal or stop and chop, what you should also learn how to do divide and conquer, especially in the soft cases. Chopping is difficult, so you go back to your basic and do a divide and conquer.
Very good one. Dr. Fong, it's an honor to have you here.
Thank you. Pleasure. So thank you very much for giving me some time to share some thoughts on Malaysia. It's about 10:30 at night here, so I apologize if I sound sleepy. It's been a long day. It's Friday night, and I'd like to share some thoughts about dividing the nucleus. So as all the speakers have mentioned, there are many techniques to divide the nucleus. First and foremost, as Dr. Dini has shown beautifully, the divide and conquer technique, which is the primary technique that almost everyone starts with. And then what I normally do is actually I move on to the divide and horizontal chop. So I mean, it's essentially a stop and chop. I think there's also the vertical chop where you don't actually do a trench. You have to be quite brave to, and I think a vertical chop really is more advanced technique for very confident surgeons. Of course, as Dr. Ivo has talked about the pre-chop, we can use a manual Akahoshi technique, or you can also use a femtosecond laser to divide up the nucleus in situ for you before you go in there and then help divide it. And of course, many, many more. But I think the key really is to have a consistent technique, whether it's divide and conquer, stop and chop, vertical chop, or pre-chop, that you can reproduce for all types of cataracts. It's good to be prepared. But generally speaking, in my 20 years of ophthalmology, I think we need to have a consistent technique that we can use it all the time. And also, it's helpful for our operating theater staff and our nurses to know that your technique is the same, so they don't need to get different instruments each time. So what I use as a second instrument is this one. I use the Barrett Nucleus rotator, which is essentially a horizontal chopper, which is a blunt tip, but quite a long horizontal chopper at the end. And this is useful because I find I operate a lot of high myopes and post-vitrectomized eyes. And this relatively long horizontal chopper allows me to go quite deep into the eye to divide it adequately. And of course, there's a little mushroom tip on the other side of this in second instrument, which is very helpful for micro maneuvers in the eye, for dialing the intraocular lens, or manipulating any iris tissue that may come out. And this is my Phaco settings here. I generally use the Stellaris PC for most of my cases because I do a lot of combined Phaco vitrectomy as I'm a vitreoretinal surgeon. This is on the left here is the Sculpt setting. So I use a relatively low bottle height, about 40 millimeters mercury, ultrasound power of 30%, and with a pulse rate of 120. And once I've used the Sculpt technique and I've managed to create a central trench and divide, move on to the segment removal setting, which is a higher vacuum, higher flow into the eye, and remain same power but a reduced pulse rate. So I don't want to push the segments away when I'm phacoing. I want to hold it in position 1, and then when I've chopped it, I can go in position 2 to emulsify it. So I've got 2 videos to share with you. The first video really is more like a straightforward case that I did last week. It's a 72-year-old lady with a 2+ nucleus sclerotic cataract, and I've already done the CCC and hydrodissection. So you can see here, I'm beginning the Sculpt centrally. I don't go beyond the rhexis margin. It's important you go for a deep trench just before the posterior capsule. And the way you know how deep you are is immediately you see the red reflex there. When the red reflex stops coming out clearly, then you should stop. You don't want to go beyond that. But also you can feel the lens giving way as you're going through. So I'm quite happy with the depth there. So I've done the initial trench on this side, and then now I go in with a second instrument. So I reduce my maneuvers in the eye. I keep it very stable. I don't want too many instruments in the eye unnecessarily. And there you have the horizontal chopper going in. As you can see, it's relatively long, but it rotates the nucleus beautifully. And so I rotate it 180 degrees, and I complete the trench on the other side as well. So it's less than 30 seconds if you ask me. And so I'm very confident I've gone right through the central nuclear plate, and the posterior plate is going to be quite easily to divide here. So the next step is so as you can see, I actually hold the Phaco probe in the middle, and I use the second instrument to just divide it. So the Phaco probe is just more to hold everything in place, and then it's nicely divided. So now I go to the segment removal setting, and I go to high vacuum, and I hold the deep center part of the nucleus, and I don't go beyond the rhexis margin, and I just dig in with a horizontal chop, and I just pull apart. And you can see the nucleus is divided quite beautifully. So this is a classical horizontal chop technique. So you've got a quarter segment there that you can safely emulsify in the central part of the the eye without going. Obviously, you want to be mindful of endothelium. Don't want to damage endothelium too much. And it's coming out beautifully here. So once you've done the division of the nucleus into half, really, you are home. Most of the work is already done. And that's why I think this topic is so important. So you can see here, the second half, the nucleus is easily chopped. Sorry about the disturbance there. And I think that's it for my first video. I'll move on to the next one. So yeah, so I've already chopped it and it's done. So this is a second video here, and this is a more difficult case. This is a very common scenario. My vitrectomy patient that had a macular hole repair about a year ago, she's come back with a nucleus sclerotic, 3+ nucleus sclerotic cataract in the eye, and now requires phacoemulsification. So you can see it's very different to the previous case. I have to increase the phaco power. I'm having a bit of difficulty grooving in the central trench. I can feel resistance, but it's important not to push the lens with your phaco probe, but let the phacoemulsification do the work. If you're feeling it's not giving, you should either increase your phaco power and groove carefully. I'm only going in the middle. So now I know I'm not deep enough, but I just want to work on the other side of the trench just to get more of the central nucleus out. So so I'm really being very careful. I'm not pushing. I don't want to cause any zonular dialysis. And you can see the central trench there is coming slowly. But I'm still not deep enough. I don't see a clear reflex. I try to divide here, but it's not possible. It's not giving way. The posterior plate is not divided here. So you don't force your way here. So what you do is go back another time. Just rotate the nucleus again and try again from the other side. Go a bit deeper in, be very careful. Obviously, it may suddenly give way. You don't want to cause a posterior capsule rupture. So I'm continuing the trench. I really need to see a deep central trench with a nice red reflex coming up. So I try again here. Again, it's not deep enough. So I don't force it. I rotate it again, 180 degrees, going back the other way. So take your time with this. It's going to be a difficult case, but we are prepared for it. Good thing is the pupil is nice and dilated. My flow settings are very low, so I don't get any floppy iris, and that's quite common in post-vitrectomized eyes. So you take your time, and it's coming slowly. Once you get through that central bit there, it's much easier. And you can see, there you go. It's easily cracked into half. So I complete the crack there. So you can see there's a nice linear crack all the way through the posterior plate there, and I just separate it on the side as well. So there you go. You can see the nice reflex. So with the cataract now safely divided into half, I go into the chop mode. So I go into the segment removal. I try and grasp deep into the nucleus, but it's not deep enough here. You can see I'm not able to complete the chop. So I go slightly deeper, hold the nuclear fragment. I don't go beyond the rhexis margins, and I just go in with the segment, and there you go. It's split into half very easily. I don't really have to do too many maneuvers. I don't want to disrupt the zonules at all. So that's 1/4 out, and then the second quarter there, and it's just coming out very slowly. And again, I'm very mindful that, this is a relatively dense cataract. You don't want to traumatize the endothelium. I try and phaco in the iris plane away from the corneal endothelium. So be very careful. And using pulse mode really helps reduce the amount of phaco energy you're using in the eye. So then it's the second half of the cataract there. So it's much easier now. So I know I have to go a bit deeper. I'm holding it with high vacuum. And there you go. I'm going in with a chopper, splitting it apart, being very careful there. And there you go. So most of the cataract is split now. There's coming in quarters, just a bit more attached at the posterior, but because it's already cut in half, it's quite easy. And then once you can sometimes just hold the nuclear fragment and then chop away with your horizontal chopper just to divide it easily. And then it comes in bits and pieces, and it's much easier there. So with that, that concludes my presentation. Thank you very much. I'm happy to answer any questions.
Very, very interesting. Are you also a VR surgeon?
Yes, I am.
Oh,
yeah. So I apologize for
that.
being in the anterior segment forum, but I think it's good. I learned also. I mean, cataract surgery is a fundamental skill for ophthalmologists, but I think as a VR surgeon, we tend to be a bit braver. We are a bit braver to go in posterior capsule nearer, but I think it's the same. You don't want to rupture the PC. Definitely you want to stay away from the posterior capsule. But a lot of the vitrectomized eyes end up with me. My anterior segment colleagues are much happier. I handle them. I do a lot of posterior polar cataracts. So, you know, we have to have a very solid phaco technique to handle these difficult cases.
That's a very good concept. First, I wanna also thank Dr. Luz Maria Melo, our angel here in Phaco Mentors. She's translating into Spanish, so we can have a bigger audience. Thank you, Luz Marina. She's a great cataract surgeon. I will love her comments too. Ishake, now it's your turn, please. And we thank you for all the tips, Ken. I think they were very amazing.
Yeah, can you see me?
Yep.
Share my screen. Yeah. Is it visible?
Perfect.
Okay. So I'm going to be talking on rotatory chop. This is a form of horizontal chop, and so the basic difference between a chop technique and divide and conquer is that use of vacuum while we are dividing it. In horizontal chop or any sort of chop, we use the vacuum, and in divide and conquer, we don't need to use the vacuum. Rather than we use two instruments, and in chopping, we hold the nucleus with vacuum, and then with the other instrument, we separate that nucleus. So the vacuum has to be appropriate according to the grade of the nucleus, and we have to be in foot position too. If we have too much vacuum, we can suck the nucleus material into the Phaco probe and thus lose the grip. And if the vacuum is too low, we don't get a good purchase, so we can't chop. So I'm going to show a rotatory chop, which was described first by Dr. Christos, and he just mentioned it in a couple of weeks back, and I just thought that I would give it a go. So I tried in some different density of cataract. This was a white cataract, the choppy type. It was not too hard. So what the concept is that we have to create two holes, like that dialing rotatory dial that we had in our old telephones. I don't know how many of the young guys have seen that. And then once those two holes have been created on the opposite side, now with the appropriate vacuum, you go in, buzz it in the nucleus through that one of the holes that you can see, and then bring that other instrument towards it. And then you have divided the nucleus into half, and then the rest of the nucleus, I always do what I have been taught by Dr. Vasavada, vertical chop and lateral separation. And this is my technique, and I use this for the rest of the part. But this is what I felt that, rotatory chop in this mobile sort of things, it works very nice. So this was a white case, and I could divide it easily. This case was a little bit harder. It was grade 4. And you can see all the things coming up while I was doing that sculpting, just sculpting vertically to create a hole over there. And I use this plain spatula still to rotate, and then create another hole on the opposite side. Sorry, I think a little bit out of this screen. And then once this is done, so you'll see that the vacuum was 80 here for the sculpting or making that hole. Now I have increased it to 400 or 500. And with the appropriate vacuum, it goes nearly to 500. Bring the chopper towards the Phaco probe. And if we lose the grip again, hold it again. Make sure that we have got a very nice vacuum. So you can see that the vacuum was going above 500. So appropriate vacuum setting and positioning the second instrument, holding it on the upper 1/3 as Vaishali was mentioning, then chop it, and lateral separation. So this hard cataract was managed through this technique. So I just learned it. I thought that I would share this. And every technique has its benefits and demerits. But it's good to have all the techniques in your bag and find out what one suits in your hand best. As Dr. Ken said that, it should be reproducible in your cases. So thank you.
Simply amazing, Ishtiake. So I think here the very interesting concept is there is a technique we saw a couple of weeks ago. You were able to understand it, to implement it, and now to show it. I think that's very, very good for all the community. Thank you very much. Now it's my turn. I'm gonna go really fast because I also want Julio to go, fast and show his technique, and then we can have some discussion. Okay. So the only thing I want to mention here is that every of the panelists is talking about the 3 pillars we love in Phaco Mentors and Ophthalmo University. We're not only talking about the motor skills and how to move your hands, but also about the decision making, the cognitive skills, right? Vishali was talking all the time, and Ron too, everybody, Dini as well. How do you need to make decisions very fast? You need to have an algorithm. Yeah, I go this way or that way. And also, we're talking about the mindset skills. Whether you like it or not, we're talking about, okay, you try to chop, it doesn't work. You go back, you relax, and go back to divide and conquer. Those are very, very important things that need to have in the mind of a surgeon. Remember, guys, this is a journey. So first, we need to be competent. We need to know about what we're doing. Then we become good and we have acceptable outcomes. Then we become great. We have same results in every single case. We can have managed complex cases. And then why not? We can become masters and be mentors and be creative and invent new techniques and instruments. My only advice is to try to take the patient outside the learning loop. Take the patient outside the equation and learn as much as you can before you enter into the operating room. The second thing is for those who really want to become a cataract surgeon and want to mentor, and they're trying to make it, they can have they can take a picture from the QR code, or that's the link, and you give us a little bit of your your name and some information, and we will be putting you in touch with mentors. Just very fast, I'm gonna go to because what I'm gonna do is to share you something that happened in Ophthalmo University. Okay, and this is for you guys. You can find it like this: crack the code in Ophthalmo University in the YouTube. Why? Because I don't want to talk about pre-chop while we had this amazing panelist. As you can see here, we had Ron Yo from your side of the world, amazing surgeon, talking about pre-chop. But we also have 2 very, very good friends you can see here. Let's see if you can see these guys. Sorry, it went to there you go. Sorry guys, this is so cracking the code. It's in English, so everybody can see it. As you can see there, we had Jonathan Lake from Brazil. There is Ron. It was me. We had, let's see, I want to show all the panelists together so you can see. There you go. Okay, so we had these guys. We have Ron, we have Takashi, and we have Jonathan Lake. The first thing about pre-chop is it has a couple of tips, but can be so helpful. First, in a nucleus that is not that dense, and if you do a correct technique, you can pre-chop it with no ultrasound. But then, for example, if you're sculpting and you cannot make a correct technique, like Dini was saying, then you can put viscoelastic, and the pre-chop can help you very, very big time in cracking that nucleus. Okay, so I actually have the minutes. For example, in the minute 15, let's see here, this is my technique to do pre-chop. You can see it there, right? Let's put the screen big so you can see it.
Yeah.
There you go. There you go. You can see me, doing the pre-chop, and we're doing like a trident in so you don't have to rotate it, and then I do pre-chop again, and I have 8 fragments. The key for pre-chop is to understand the nuclear density and how deep the pre-chop is going to go into the nucleus. Okay. The second thing is you can do little movements so you can enter more into the nucleus, because if you're not deep enough, you will not crack it. Um, but always be careful with the sonula. You just don't want to, to go that deep that the sonula is suffering that time. Then in minute 21, so everybody who wants to know a lot more, there we have the amazing Ronald Yo, who is also, talking about the indications of karate pre-chop. And you can see there, see, oh, he's not doing pre-chop there. There you go. Let's see. Okay, but I didn't want to take time, and I want to tell you that everything is in this video about pre-chop. Then in minute 41 we have the amazing, I want to show you this one just to finish. We have Takashi. Let's see here, and this is Takashi Ida, a very, very good surgeon too, and telling you exactly with the high definition how to do a correct pre-chop. Look at that image, okay? And how it's something that he will not do fast. In pre-chop, you need to enter in the correct depth of the nucleus, and then you can go slow. You can rotate the nucleus with the pre-chop, and look at that beautiful 4 fragments. Look at that, more fragments, how easy it is to emulsify that nucleus after you crack it in so many places. Can you see that? Look at that. That's easy to emulsify, right? So just to finish, something amazing in this video too is in minute 54 that we have Jonathan Lake doing this, guys. Look at that, visco fracture. So you can be creative, and you can even crack a nucleus that is not that deep with viscoelastics. So again, my advice to you is to see that video, and if you have any questions, please ask them like in the chat. And Julio, the screen is yours.
Okay, good day. And in honor to Ivo to preserve that tricky point he said about endothelium, don't rupture the capsule and don't damage the sonol, I present to you the Ultra Phaco. Ultra Phaco is a way to divide the nucleus with a modified Kelman tip that have a knife shape. Is created by my mentor, Dr. Scaff, in 2004. And you can see here in the video, you can put this tip in all the Alcon system. I have no financial disclosure in this talk. And this video is really important, that I want to show you that the Ultra Chopper technique is really safe and reproducible. The Ultra Chopper has 2.5 millimeters, so you don't, as much as you go deep into the cataract, you don't go through, and so you it's almost impossible to rupture the posterior capsule. So this video, the doctor's caps show every time to all the fellows to don't get scared to use it. If you go 90 degrees through the cataract, you don't go, you have a safe margin, you don't go to the posterior capsule. And here you can see in a wet lab how you can cut a hard rock cataract. And if you measure the Ultra Chopper, you can see that you have a safe margin, and it's almost impossible to rupture the posterior capsule. This is the Ultra Chopper shifting, and the instrumental. You don't need all, but to know it, you have the nucleus divisors, the first one. Then you have the nucleus sustainer that is the one I use in all my cases. Then you have the nucleus manipulator that is like a spoon and to do a soft movement. And recently you have the scuff-free chopper that is so thin that you can go and separate the fragments after you do the ultra chopper. Here are the parameters for all the Alcon machines in the Infinity that you fix the Phaco power at 60. You can go, if it's not too hard, you can go from 50, and if it's a hard rock, you can go easily to 70. Low vacuum and a high aspiration rate, and the higher of the bottle or the PO is standard. And here you can see the Infinity, the parameter in the constellation is the same, and you only need to modify in Centurion because it's no it's not a bottle, but it's IOP, so you have to put a low IOP. And there are different techniques for use it. The first one, when you started, is a divide and conquer, but with ultra chopper. And the advantage that have the ultra chopper if that this tip cut with forward movements and backward movements. So in both ways, you have a cutting, and you can go back and forward and have the same results. And then you go with the divider, nucleus divider, and separate all the fragments. So this is a demonstration from American doctor from Iowa, Jason Jones, and you can see he start at the edge of the anterior capsular rhexis and go forward and backwards and make a sculpt in the center of the nucleus. And then with the divisor, you separate the fragments. It's important to remove the epinucleus because you want to engage the nucleus, the hard part. So first in a pre-chop settings, you aspirate because the ultra chopper have irrigation at the sides and aspiration with the sleeve. So you first remove the epinucleus, then you do the divide and conquer with the ultra chopper, and then you with the nucleus divisor separate the fragments, and you can make all the fragments that you want. Then this is my preferred one that I perform most of the time, is with the nucleus sustainer. And it's more tricky because you have to go to the quadrator, but if you are get to use to the horizontal chop and Phaco chop, you can do it. And here's a demonstration. With the sustainer, you go to the equator, hold the cataract and lift a little bit, and then with the ultra chopper, you go from the proximal part of the anterior capsule to the other side, and with mechanical movement you can complete the cracking. And in this technique you can divide really hard cataracts with minimum CDE. So here is a demonstration of doing that technique. You hold the cataract, lift a little bit, and then go with the ultra, and you get a nice cracking. And more hard, more cracking you do. And this one is more likely for soft nucleus. You start with the chopper, perform the sculpting, the dividing, and then with the scuff pre-chop, you go inside this thin sulcus and separate the fragments. And here you can see, you start like, it's like a divide and conquer, but with irrigation and a really good anterior chamber. And then when you have all the fragments that you want, you go inside with the scuff ultra chopper, and it's so thin that you go inside that sculpt, and you can separate all the fragments and then do the phacoemulsification. So like Phaco mentor says, you want to go from good to great, and this is me 10 years ago with one of my mentors, Dr. Amelo, who is translating right now. That he was the one who let me do my first complete case. At my first 3 months, I was trying to learning all the techniques that you said, Phaco chop, vertical chop, divide and conquer. But when in my hands I get the ultra chopper, in the first case I did a complete case. So that's when I told you that it's reproducible, short the learning curve, and you can make really difficult cases, hard work cataracts in a routine for you. So if it's a routine, you don't get scared every time you're gonna do it. So this is me like 10 years ago, and now you can afford this really hard nucleus with confidence. Don't get scared. So you make this case a routine for you with this technique, and try to avoid extra cut as much as you can, because you can afford really hard nucleus. So in summary, I want to tell you that it's safe. You can go as deep as you want with ultra chopper, and it's really impossible to rupture the capsule. You preserve the sonal. All the ultrasound is in the tip of the ultra chopper, so it's go all through the cataract, not through the endothelium. It's reproducible. Shorten the learning curves in all the residents that are learning Phaco, and you turn something difficult like a hard rock into something easy, because you can crack every nucleus that they put on in the OR. So thank you. That's all I have for you.
Thank you very much, Julio. And she is translating, but we want her to stop translating and give us a couple of comments, because she has so many experience with the ultra chopper. Dr. Luz Maria Amelo, thank you for being here with us. And we will love also some insights about the ultra chopper.
Okay, well, it's my pleasure to be with you, and thanks you for inviting me. It's a pleasure to be here translating and help you out, and to sharing our tips and all of this community, and see all you experts, also surgeons, doing and showing your own techniques. Well, I think it's for residents and people in training, it's good to see all of the techniques we've shown, because everybody can get what's suitable for them. Regarding to ultra chopper, I can add to what Julio said, that it was also an amazing presentation. Julio, very proud of you. It was has been a very good surgeon, very great skills. Is that Dr. Alan Crandall's Oscars-winning video in 2011 with a Miyake camera? He showed that the ultra chopper did not produce any stress to the sonula. So it's very safe also to use it, and also in difficult and challenging cases, such as when you have a plaque, Argentinian plaque, or also subluxations of the sonula, because the ultra chopper does not destroy the sonula. Maybe two things to add is that I've seen most of the surgeons had at least 90 degrees of separation between the two incisions. For us, we think also that's very helpful. But there one surgeon that he liked to, Dr. Kang Fong, for example, his incisions were closed one to another, but that's his technique and his comfort with them. And it's good for people to see what's comfort for every person. The other thing that I could say is that it's important to put in the position 2 of the pedal. For us, that's very important, a long position 2. The long position 2, in order that you can play a little bit more with the aspiration. We usually here in Latin America, more of 70% of our cataracts are very hard cataracts. But sometimes, as we are moving on to be more refractive surgeons, soft cataracts are coming in. So we need more vacuum, and we have to be able to play with that vacuum. So it's very good to have to set up the position 2. Well, maybe congratulate everyone, because really the expertise and all the videos were great, and invite you to use also the ultra chopper, because you're going to see that the learning cube is very easy, and the CDE is very low, and you can crack really hard cataracts, well, very easy. Julio showed it to you in a very nice way, and we really are sure of that. Thank you.
Thank you very much, Luz Marina. It's a pleasure to have you here always. So we're finishing, great timing. But before we go, I will love, first there was a question, there was a quick question about how you put the foot pedal when you're doing sculpting. What we like to do is you go, when you're advancing, you go in position 3, and then when you come back, you are in position 1. Okay. The important thing about when you, but there's a tricky here thing about the decision making, right? So what you want is that the displacement of the Phaco tip is smooth. I don't wanna, you wanna traction the sonula. So which ultrasound you're gonna put, the ultrasound good enough for that tip to displace correctly. I think that's a very important tip and a very good question from the audience. So we're gonna start with the panel, and I want a final comment, especially about what we did today, because for one problem we gave many solutions. So here I think the key here is the decision making and the problem solving, because there is not going to be 2 cataracts that are going to be the same. So you need to know many techniques and apply them in the correct moments. So Vishali, you can start, and I would like a final short comment about this.
Sure. So I think I enjoyed this. And like you said, everybody, when you start off, you should know what are the options. And then I feel that in your beginning stages, decide 1 or 2 techniques. For example, for a hard cataract, I have 1 and 2. And for a soft cataract, I have 1 and 2. So that I can master that first. And then I can always, once I am a master in that, then I can do everything and anything. But first know everything, try once or twice, and then choose 1 or 2 techniques and then master that. That's my tip.
That's a very interesting comment, and I think we should keep talking about it, right? Is it good that you have 1 or 2 techniques that you really master, and then you just forget about the other, or you know about different skills to face different cataracts. Very interesting concept. Nini, what's your final comment?
Yes, for me as a beginner, I always suggest to the trainee start with divide and conquer. If you expertise with this, you can modify it with stop and chop and others. Because I think it's the basic. If you get difficult or hard situation, we can fix the problem with DNC.
Thank you very much. Dr. Fong?
Really enjoyed the session today. I have to admit, I have tried our pre-chop before. I didn't have a very good experience with it. I think we've evolved a lot. I started Phaco in 1999, so that's how old I am. And back then it was so different. One thing I agree that you need to have a good technique, divide and conquer or stop and chop. But one thing that's changed my practice in the last 5 to 10 years is actually the torsional Phaco. So I have other videos of even denser cataracts that I've used with the Centurion system. And I found actually it makes it so much easier with a good torsional Phaco probe. And that technology itself has really improved our Phaco. And I rarely do extra cap nowadays, even for very brunescent cataracts. So thank you very much for allowing me to share.
It was an honor to have you. Thank you, Dr. Fong. Ishtiaki?
Yeah. Couple of things that Dr. Marina mentioned, that side port, positioning of the side port. I could see that Dr. Fong was very close to his incision, but it varies whether you are doing horizontal chop or vertical chop. For me, I would place it 90 degree apart, and these little things, it has very much value when you are doing. And another thing I wanted to know, that how many fragments would you go for, Ivo? Sometimes we are obsessed, trying to make many. 8, 10. So how many is good for it? And I just wanted to know to Dr. Marina and Dr. Julio that, in soft cataract, do you also use the ultra chopper? And then once you are done with the chopping, do you have to change it? To change it with the traditional tip?
Well, with a soft cataract, we can do the first group with the ultra chopper, and then we can divide with the pre-chopper. and that's more than enough. Or sometimes they are so soft that we just can introduce the pre-choppers. A scalp pre-chopper, it's thinner and it's very sharp. So you can introduce the pre-chopper and just doing a small movement, you make the little groove and then you can split it into 2 parts and afterwards in 4 parts. So sometimes maybe we use in hard cataracts and soft cataracts, not as soft as on nuclear 3, we use just the pre-chopper and that's enough.
You remove it and then you again attach the normal tip. That's what I wanted to know.
Well, we use the balance tip. The balance tip that we use we have the Centurion, we use the balance tip.
You have to change it.
Yeah.
Well, the Centurion it's able to handle two instruments. You can set up a Phaco tip with the balance tip and the Phaco tip with the ultra chopper tip. And right now, that was the disadvantage that the ultra chopper had, that it was just for the Phaco, for the Alcon machines. Now, this is a breaking news. Ultra chopper is coming separate, and it will have also a mode in which you can cut the intraocular lens in cases you need.
Right. I'm going to try that once I have that tip.
I have a question, sorry to interrupt, but is the ultra chopper still available? At least in India, we stopped getting it a few years back. It came for a short time and then Alcon doesn't give us any more.
Yeah, right now, Alcon doesn't have the patent. The patent is, again, for Dr. Scaff. And I think in the next coming month, he'll be up the new ultra chopper that's going to be separate from any machine so that you can use it. And you will have also the device to cut the intraocular lens as well.
Tender some so that we can use.
Yeah, Julio, final thoughts, and we can finish.
Yeah. Well, the final thought that everyone said, you have to master one technique. For me, I choose ultra chopper like a way to go to the OR. I perform in 90% of my cases. I don't use it in phaco-refractives, but in all the other cases. And you need to know that you have variations. When you have a small pupil, when you have polar posterior, you can do the anti-block technique with the ultra chopper, so you don't get a anterior capsule block and then a posterior capsule. But like it's a ultra chopper system, so you have like a really good variation. So you have to do the whole course to know all that. But basically, you can crack everything that they put you in the OR. So make hard rock cataracts your routine, so you don't get scared when you go to the OR.
Okay, thank you very much. Thanks to all the panel. We would love to have you back to talk about these amazing topics. I think the timing was great. People are very happy with all the skills they're learning. So thank you very much, and stay in touch. Okay, guys.
Okay.
Thank you, Ishtake, for all the effort.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you. Bye-bye.
Good morning, good night, good evening.
Good night. Bye-bye.